Theory and Interpretation. I'm Eric McCuster, almost 2, and I am a former monitor tech at the La Palma Intercommunity Hospital in La Palma, California. I only worked there for 9 months, but I got to see a lot of stuff working in the telemetry ward there for the night shift. I will admit firsthand that I'm definitely not an expert, but hopefully I can introduce you to some of the basics that you might not have seen before, and hopefully that'll get you on the right foot so that when you start studying and interpreting EKGs on your own, you won't be quite so in the dark. So moving forward. Alright, first off, just copyright notice. This presentation and video are going to be released as Creative Commons Attribution, Non-Commercial, Share-alike documents. Everything here is either in the public domain or shares a Creative Commons license. Therefore, as long as you follow the restrictions listed on the individual parts, it can be shared without any fee. So that's always fun. Information wants to be free. Alright, so starting off, we're going to go for a little physiology review. Just to describe EKGs in a nutshell. An EKG measures changes in voltage across 2 points. Those 2 points are electrodes that are placed either on the skin of the patient, or there are some leads that have electrodes that theoretically originate in the heart, the electrically active centers of the heart, and then there are electrodes that pick up the change in voltage from the heart to the skin. This electrical activity is just the depolarization and repolarization that occurs in the cardiac muscle cells as it extends from the cardiac muscle through the surrounding tissues. These depolarization-repolarization events, based on where what lead is being observed, will have an expected amplitude and directionality. Amplitude is the degree by which a spike moves on one side or the other of the isoelectric point. And the deflection is the directionality, whether it's a positive deflection or a negative deflection. The image that you see on the screen is describing how waveforms relate to the direction of electrical charge moving towards a positive electrode. In ECG measurements and electrode placement, the depolarization events and repolarization event all progress towards the positive electrode. And the direction is in a line originating at the negative electrode. When you see a signal moving towards the positive electrode, you will see an upward deflection. If there is a situation where a signal is actually moving away from a positive electrode, and this can be seen in the non-standard lead, the standard lead by which we make all our normal measurements is lead 2, which I'll discuss in a moment. If you have another lead, for example, not necessarily lead 2, where the signal is actually moving away from the positive electrode, you will have a downward deflection. And if you see a complex that has an upward and downward spike, you're seeing 2 events. The first event, which is showing an upward deflection here, labeled by A, is an event where the signal is moving towards the electrode. B event occurs later in time. It's detected later by the electrode, and it is moving away from the electrode. Basic review of EKGs as a machine. The 12 lead is the gold standard for cardiology. However, there are many different types of EKG machines. Personally, I was most well versed in using a 5-lead wire system. I could not tell you off the top of my head how many actual leads that represents, but I've also worked with 4-lead wire systems, and I have worked with 12-lead systems as well, which are technically 10-lead wire systems. The reason that there's such variability is that, for the most part, the 12-lead EKG is only indicated in acute conditions and for thorough workup. In a situation where a person may not have cardiac issues, a more minimal approach may be appropriate. Most commonly in emergency rooms, you'll see a limb lead system, just 3 electrodes, 3 wires, placed on the anterior chest. In a telemetry ward where I worked, we used the 5-lead wire system, and we could get a large number of leads, the theoretical leads, which I'll discuss in a minute. Basically it. Alright, so just remember that you may not see a bunch of wires on a patient. You might see only 3, you might see 5, you might see 4. It really depends on where you're at and why they're on the monitor to begin with. Okay, now this is a really important point that leads to a lot of confusion, and I know that it led to a lot of confusion when I was taking my introductory course. Number of wires does not equal the number of leads. Unfortunately, the English language likes to use the word lead to refer to the wire as well as the theoretical lines that connect to electrodes. These theoretical lines are not represented by a wire. It's the body itself acting as a conduit, a wire, between the 2 electrodes. Their polarities are standardized in reference to each individual lead. An electrode could be a positive electrode for one lead and a negative electrode for another. We'll go over that right now. Okay, the limb leads. We first start off with this schematic triangle, which is named after Dr. Einthoven, who won the Nobel Prize in Medicine for discovering the electrocardiogram. First off, the electrodes. We have the right arm electrode, the left arm electrode. Note here, there is only one electrode, but it serves a dual purpose. In one lead, it is the positive electrode. In another lead, it is the negative electrode. And then the left foot lead. You'll note that I put these arm and foot designations in quotes. That is because we rarely put them on the arm or foot, at least when doing a non-12 lead setup. 12 lead setup, yes, you probably will put them on the arm and foot. It'll give you a more accurate measurement, and it's more standardized. For telemetry monitoring, typically, because the patient's going to be walking around, hopefully, if they're doing well enough, or at least being somewhat mobile, and wearing the monitor for a considerable amount of time, having to use the bathroom, things like that, we usually place the electrodes inferior to the clavicle, mid-clavicular line. The left foot lead, usually we put left upper quadrant inferior to the costal cage, or at least not on bone. Now the leads connect these electrodes. Lead 1 connects the right arm with the left arm electrodes. Lead 2 connects the left arm electrode with, the right arm electrode with the left foot electrode. And finally, lead 3 connects the left arm electrode with the left foot electrode. Okay, so limb leads and anatomic relationships. This chest x-ray shows a good schematic of how Einthoven's triangle works. The situation that is presented here is lead 1 will show changes in voltage across the base of the heart, the top aspect, superior aspect. Lead 2 measures changes in voltage from the base to the apex. Now, from the base to the apex is also how the electrical signal travels through the heart. That's why this lead is considered the standard lead. Lead 3 changes in voltage across the apex of the heart, or the bottom of the heart. Not typically used very much. I don't recall using it for measurements as a monitor tech, but then again, I wasn't doing very many fancy measurements. Perhaps in the future we will see if lead 3 garners more importance than I've seen in the past. Okay, moving forward, we have another triangle. These are the augmented limb leads. These limb leads, in contrast to the standard limb leads, are unipolar. There's only one external electrode, and they are shared with the electrodes of the previous triangle, Einthoven triangle. The negative electrode is the same for all of these, and it's centered at the heart. These electrodes are measuring changes in voltage in a more three-dimensional plane. The standard limb leads are measuring in a very two-dimensional plane across the chest. There is some three-dimensionality that can be interpreted, but it's kind of like a flatlander problem. The augmented limb leads allow us to get a little bit better picture of the three-dimensional travel of electrical impulses through the heart. Finally, we have the chest leads. These are also unipolar leads, and they are used primarily to look at bundle branch block and to distinguish supraventricular tachycardias from other forms of tachycardia. These are typically not used for determining axis because they are unipolar and they're primarily focused around the ventricles. Hence their use as bundle branch block leads. There are even more chest leads that can measure electrical changes along the posterior aspect of the patient. Those are not used very frequently. Typically, they are only used in a patient that cannot lie supine, and the computer systems must be appropriately configured to support that. Otherwise, you'll get very odd deflections. And then there are some modified chest leads that are actually bipolar, like the standard limb leads. They use the left arm electrode as the positive electrode, where V1 and V6 are the negative electrodes. Now, if you combine Einthoven's triangle and the augments of Goldberger, which are the augmented leads, you'll notice that they bear a striking resemblance to the hexaxial reference that we saw earlier yesterday. The hexaxial reference is based on the concepts of Einthoven's triangle and the augments. The position of the limb leads does not always make a perfect triangle, but we can use this triangle concept to map out how we would expect deflections to move through the heart. We will get to how the hexaxial reference is used in axial deviation measurements in a few slides. This is the standard waveform. This is a textbook perfect You'll probably rarely, if ever, see this waveform, and it is from lead 2. Recall that lead 2 measures change in voltage from the right arm or shoulder to the left foot, or left upper quadrant of the belly. The reason for using lead 2 is that it measures change in voltage from very near where the sinoatrial node is, all the way back down to the apex of the heart, and then splits the ventricles pretty much in half so that you can see the strongest peaking for all portions of a cardiac cycle. You will note on this diagram that each of the individual waves represent a particular section of that cardiac cycle. The P wave represents atrial depolarization. It is, in lead 2, the progression of the atrial electrical impulse as it moves from the SA node into the junctional space in the AV node. The QRS complex as a whole represents ventricular depolarization. The Q wave is the septal depolarization in between the ventricles, and it is the septal wall itself, not necessarily the bundle of His. Bundle of His is a bit more protected from the outside, and it's not usually measured except by pacemakers. The R and S waves, or spikes, are the simultaneous ventricular wall depolarizations. And you're probably thinking simultaneous, but they're not occurring at the same time. There's a gap in between. I'll show you on the next slide how that happens. And then finally, the T wave represents ventricular repolarization. Repolarization? What happened to the atrial repolarization? It happened, but it's buried in the QRS complex. Because the atria are much smaller than the ventricles, and the ventricular impulse is a lot more powerful, the atrial repolarization phase is buried within the QRS complex. It is not a distinct entity because it is overwhelmed by the signal from the ventricles. There's also, in some rare cases, an additional U wave. No one is entirely quite sure what the U wave is, and it only shows up in rare cases. We will not discuss the U wave too much in this lecture. If it comes up in a future lecture, that will probably be more appropriate discussion for that time. Here, we're looking at the waveform in motion. It's a very slow GIF. Yes, GIF, not GIF. That's showing the progression of the electrical impulse and the corresponding movement of the cardiac muscle. The beautiful thing about this animation is that it also shows in real time the appearance of the EKG waveform. You will see on the next beginning of the next cycle, which we'll wait for just a moment, sinoatrial node fires, atria contract, collects at the AV node fires, bundle of His and Purkinje fibers send the signal throughout the ventricular wall. The ventricular walls repolarize, the cycle completes, and then begins anew. Amplitude and deflection. This is where we get to discuss why R and S don't happen at the exact same time, despite the walls of the ventricles contracting at about the same time. Recall that the left ventricle is larger because it must pump the blood into the systemic circulation, whereas the right ventricle pumps blood into the pulmonary circulation. where there is a much less pressure and less space to fill. You'll see here that I made a little diagram with the Gray's anatomy plate. The red line that you see anterior to the chest wall represents the imaginary line that is lead 2, moving from the right arm to the left leg, quote unquote. The signal that is coming from the anterior aspect of the heart is the left ventricle and a little bit of the right ventricle, but not much. The left ventricle is extremely strong, so we get a very large positive spike in the R wave. It's positive because it is moving towards the anterior chest, towards the lead. And specifically, not just towards the imaginary line, but it's also moving towards that positive electrode. The posterior aspect of the heart, which includes most of the right ventricle, is firing its impulse, and that impulse is traveling posteriorly, away from that positive electrode. It also has to travel a longer distance. That longer distance causes the time delay, which is why you see the S wave following the R wave. The deflection is negative because it is traveling in a direction opposite that of the R wave. The signal that's being perceived is going in a direction away from that positive electrode, because it's moving posteriorly towards the back of the patient. The axis principle. This is something that, as a monitor tech, very, very rarely, if ever, looked at. However, we did cover some attributes of this, and I did my own personal research as well, and based on the lecture that we had yesterday, I was able to formulate kind of a overview of what I feel are the important points in how to understand what axis means. Axis in this case is not necessarily referring to point at which around which something moves, like the axis of the Earth. It's not a rotational thing. Instead, this axis principle describes a correlation with lead of greatest amplitude and the region of the heart with the greatest mass. This explains why lead 2 is traditionally considered the standard lead, because it usually has the greatest amplitude. Why does it have the greatest amplitude? It primarily lies between the left and right ventricle. Together, they comprise the majority of the mass of the heart. Depending on the size of each ventricle, you can have disparities in how the waveform appears. If you have an even split, the lead 2 is splitting the ventricles basically in half into a left and right side. In some situations, you can have the left ventricle hypertrophic, and you will see a greater positive deflection because the left ventricle is closer to the positive side. Remember that the right ventricle is kind of wrapping posteriorly and inferiorly. So its signal will be sent more towards the opposite side. If the right ventricle is hypertrophic, you'll see a greater negative deflection, because again, it is sending its signal more posterior and to the right, away from that left leg lead, or that left leg electrode part. As I just said, if a region is hypertrophic, axis will move towards the hypertrophy. Now, if a region is conductively compromised by infarction, for example, the axis will move away from that infarct. So you'll get a false hypertrophy because there's part of the muscle that has died, and you now will have a movement of the signal. I'll get a pointer out here to kind of illustrate. Imagine, for example, that a portion of the left ventricle, it has been infarcted. And that's going to be seen as a deviation from the line formed by the entirety of lead 2. The signal originates at the center of the heart, or the sinoatrial node, which technically isn't the center, but for schematic purposes, that's what we will say is described by this meeting point. This end represents the right arm electrode. This end represents the left foot electrode. In a normal patient, this axis is the axis of greatest amplitude. However, if there is an infarction that limits the progression of a signal down this line, down this axis, there's going to be a detour. If the infarction is, for example, let's see if we can get something going here. I'll do it in blue. Okay, so say there's an infarct right here. That infarct could send a signal to the left, or it could send a signal to the right. Note what's happening here. If the signal is going to the left, you're getting an increase in deflection on the AVL lead. If it deflects to the right, you're getting an increased deflection in the AVF lead. This is what is important about understanding non-isoelectric deflections in AVL and AVF. This occurs when there is dead tissue that is no longer electrically conductive. When that electrical conductance is lost, because the heart is a contiguous network of cells rather than just wires, that signal can make a detour. It can make a left turn or a right turn. The turn that it makes describes the axis deviation. And you can see which way that it will turn based on observing changes in deflection direction in AVL and AVF. Measurements. Measurements we did go over in the previous lecture yesterday, and I think once a bit more of the basic understanding has been gained, the slides from that lecture will actually be very useful, and you'll start to be able to recognize what is being described on those slides. To give you a little bit more background on how these measurements are made. Typically, the measurements are made either with a ruler or with a set of calipers. I greatly prefer calipers, mostly because for the most part it's difficult to, unless you're using standardized paper, which is this red paper that you see an example of on your screen, or on the screen. If you don't know if your paper is standard, especially with maybe practice material you find online, your rulers might not be accurate, just because the paper might not be to the proper scale. So I greatly prefer calipers. Personally, it's a little bit easier to see. The boxes, as you can see on the screen, one little box represents 40 milliseconds. Add up 5 of those, that's 200 milliseconds. 5 large boxes, that's 5 right there, that's a second. When measuring rate, typically, especially if you're in a telemetry ward where no one's normal, it's very difficult to use the 300 method to determine the rate. So typically what I would do is I would have a strip of 6 seconds, so 30 boxes. In that strip, I'd count how many QRSs. That's your rate. Oh, you count up that many QRSs, multiply by 10. That's kind of important. Multiply by 10, so you're taking 6 seconds, you multiply by 10, that's your beats per minute. The 300 method, which I'm going to look up just to be sure, I remember exactly how that works. Okay, for regular rhythms, you can use the 300 method. That's where you measure the distance between 2 R waves, so the highest peak on lead 2. You count the number of large boxes, and you do 300 divided by that number. So if you count 5 large boxes between each R wave, that's 60 beats per minute. 300 divided by 5. That's more math, and that's big numbers. And it's really not entirely that important because for the most part, the computer systems that do these measurements typically are pretty accurate unless there's a lot of artifact. And even then, sometimes it's tough for the human operator to distinguish what's really an R wave and what's just random spikes. Millivoltage, not entirely that important at this point. There may be future lectures that we have that stress more of the importance of millivoltage. Some people will have more conductive skin. They'll be especially sweaty. Or they might just have enlarged hearts, cardiomegaly, giving you higher spikes. Again, it was not entirely a stress point for my line of work, but it may come up in the future, so you might want to pay attention to what the boxes mean on the vertical axis as well. Okay, from here, I'm going to go ahead and close for questions and comments. You can see here that my Facebook is available. I do get notifications when people try and contact me or message me, so I will be able to respond to that. I also do have email, and I'm checking that constantly as well. If you prefer to use that method, I'm more than happy to answer any questions or to take any comments for any further explanations that I can go into. Beyond that, I think that this is an appropriate place to close. We've got a decent introduction to exactly how the leads work and the physiology behind EKGs. I'm abstaining from covering the arrhythmias, mostly because those were covered reasonably well in the previous lecture. We should get a little bit more introduction to it in the future, and I feel that recognizing these patterns is something that you'll need to have practice material for. I've been hearing a lot of good recommendations about rapid interpretation of EKGs,
by Dr. Dubin. I've thumbed through it, and it's a very baby steps approach to understanding EKGs. I'm sure that it will have a lot of good examples. I can also recommend that you look up online resources to see if there are any EKG practice problems that you can find. Those are highly recommended because they can better exemplify these problem situations. One thing that I did want to make sure that I did was make sure that this presentation was Creative Commons licensed, so I did not obtain too many example strips. If anyone would like to have a look at my textbook that I had from when I took my EKG course, I'd be more than happy to let you peruse that. Not sure about legality of sharing that through a digital means, but maybe we can work something out, or I can do some more research and lead you to an electronic resource that will help you out. Again, if you have any questions, feel free to contact me, and this is Eric signing off.